Good morning, everyone. Can you see me on? I think can see my face on Facebook because I'm also streaming. Yeah, I'm also sharing it on my Facebook. All right, we have so far we have 27 viewers. Right? Can you hear me? Can you hear me there in Facebook? Okay. I wanted to see some comments from you guys. Good morning here in Texas. If you can see, I'm wearing a Texas shirt because I'm currently situated here in Beaumont, Texas. It's just about 2 hours from Houston. So Houston is the capital of Southeast Texas. It's not Houston, which is the capital of the whole Texas. Actually, it's Austin. It's the capital of one of the big cities here. In fact, the big city, the biggest city here in Southeast Texas. Okay, so loud and clear. So can you also share iPaaS processing? I guess iPaaS processing is also sharing it to our Facebook page. And yeah, if you have a chance, kindly also share it to your social media platform. Okay. All right. So first things first. My name is Jay. I'm one of the educators in iPaaS Online Review and Mentoring Academy. Like I said, I'm here in Beaumont, Texas. It's been a while already. So I've been a nurse for quite that long, since 2003. So I've been a nurse for 20 years. I was in Saudi for about 4 years. I was in the education, not in the school, but primarily in the hospitals, doing the competencies, orientation, and all those stuff, preceptorship, and some trainings for the staff nurses there in one of the hospitals there in Saudi Arabia. I came here to the US and became a medical surgical telemetry nurse. I'm assigned in a very active floor, a medical surgical, you know that very well. And yeah, it's, medical surgical here in the US is one of the major units or specialties. And I guess it's not only in the US, I guess for the entire, world. But well, in the context of NCLEX, you will expect more questions related to medical surgical, especially cardio. That's why our topic for today is about congestive heart failure and more particularly about your cardiopharmacology. So those medications that are usually given for a patient having congestive heart failure. By the way, talking about my background, just to continue, like I said, I'm the lead educator of iPaaS Online Review and Mentoring Academy. If you see my background, it says 11 cycle. So I'm inviting you everyone to join us on our 11 cycle. It's a 3 month long not orientation but program. So we just had our orientation. So it's gonna be 3 months, but I know it's going to be temporary. Okay, just sacrifice for 3 months. Actually, you can also access it for the whole year. It's sort of like an unlimited program. If you were not able uh, to master it in 3 months, and then you can do it for another 3 months, and then if not, and then another 3 months. So that will run for 4 cycles in 1 year, because it's every 3 months. Okay, so I'm inviting you everyone to join our program, and please, we already had the figures of the percentage of passing coming from NCSBN from April to June. So it was skyrocketing from about the increase is about 15 to 20%. So I would tell you guys that this is about time to take your NCLEX. Okay, this is about time to take your NCLEX because again the figures are really skyrocketing. And what I'm thinking is that probably in the next 2 years or 3 years, they usually revise the exam in the NCSBN for every 3 years. I'm expecting that they will change the difficulty level because you know what? This is just my opinion though, because again the figures are really high. Okay, so it's just about time to take your NCLEX this time. Okay, so to those who are here listening right now, can I see the comment? If put your place where are you situated? If you are from the Philippines, put there in the Philippines. Okay. or you can put more specifically your place or your locality there in the Philippines. If you're from the Middle East, put it there. By the way, this is a joint project by Connetics. We call it Connetics College. We're doing it every Monday, okay, including the English reviews or lectures, and as well as other reviews or lectures or discussions related to your NGN and CLEX. Okay, so if you notice, I'm not gonna go discuss about case study today. All right, because you've been bombarded with case studies as the highlight of your next generation NCLEX. This time, I'm gonna discuss to you about certain concept which is also common, a very common topic in your case studies in the actual exam. Okay, so let's dig in a little bit about your CHF, especially on your cardiopharmacology, the most common medications. Miss Naima is from Pakistan, and Sheila is also from the Philippines. Please kindly share if you have your Facebook platform. I guess better if you share it also in your Facebook, so we can share a lot of informations. Again, the purpose of this Connetics College is to bring you, the informations, especially, of course, in the context of your NCLEX. Every one of us are dreaming to come here in the US, and this is also applicable to Australia and Canada. But I guess Connetics is primarily uh, deploying nurses here in the US. If you also notice, guys, this is a good start on our discussion, right? So it says, trust the wait, my background, trust the wait, embrace the uncertainty, and enjoy the beauty of becoming. Okay, you will become a USRN. Sometimes there are uncertainties along the way, but it's just temporary. It's just normal in a certain process. Sometimes you fail, but it's not necessarily a failure. What do I mean by that? Because failing is a process, all right? But failure is an end. So along the way, you will have low scores in your test, but that is not the final. The final is your actual sitting of your NCLEX. Okay? So what do I mean by that? When you like fail in your test, that means to say that you need to do more and more and more. Build, always have to build knowledge. Practice, practice, practice. That's the secret of your NCLEX. All right? So without further ado, I guess I need to, who else? From the Philippines, Maria. I guess I have to share my screen. So we can start. Hold on. I'm not gonna use a PowerPoint here, guys. Instead, I'm going to just share my drawing app so I can doodle more of your discussions today. There. There, I guess you can see my screen now. So if you notice, I think Facebook is kind of live a little bit on my end. I don't know, it's something about the signal or what. If you notice, I draw a heart, right? Okay, and I'm gonna share also some PDF files, like just a little bit of PDF files to explain more about your CHF, the stages, and as well as the medications. Okay, and then let me explain each medications that are commonly given in your CHF. Okay, it's a pretty common topic in your NCLEX, not only in your case studies, but as well as other formats of your exams. Okay, so isn't it right? And again, our purpose here is not just to pass the NCLEX, is for you to be able to keep up with the complexity of nursing here in the US. Okay, that's why they basically change your format of examination in your NCLEX, because we wanted to keep up with the complexity of the disease conditions nowadays. And one of them, of course, is your CHF. The bulk of your medical surgical concepts in your NCLEX is really big, and usually they ask you about CHF. And mind you, guys, medical surgical is also the bulk of the whole NCLEX. So it's just right for us to discuss big topics like this. All right, so let's start it off with your. If you notice, I have put in a drawing of your heart. Let's just start with the basics before you understand, the mechanisms why we are giving these medications. All right. So let's start it off with your heart right here. This is, I'm going to divide it in your, are you ready, guys? Can I get a yes from you guys? Miss Lauren is also, where are you from? Where are you situated, Miss Lauren? Watching from Ilocos, Sheila? So come on. So I need your participation also here because I'm going to ask you questions as well. Okay, and I know you can also relate if you're working right now in your certain units like medical, surgical, or ICU. You can relate to this because again, these are common situations or diseases found in ICUs, right? Yes, watching from Mindanao, we have Gimar, right? Yeah, Mikel is also from Laguna, Philippines. Who else? I need one more so I can start. Come on, guys. This is actually my start. When I do my discussions in IPAS Online Review and Mentoring Academy, I usually start it with a yes, so I can start. So at least to get your participation here. Come on, come on. One more, one more. One more, guys. Come on. Okay, Subic. It's also from the Philippines, right? The northern part of the Philippines. Not the most north, but somewhere in Bataan, right? Yeah, watching from Philippines, si Miss Lorna. So I'm gonna divide. This is your heart right here. I'm gonna divide it into two. All right. This is your left portion, and make use of this white pen. This is your left, and this is your right. Okay. I mean, sorry. That's on my left. No, this is your right, and this is your left side of your heart. Let me just draw something like a heart. So right-sided and left-sided. You know where I'm going here, right? So I'm gonna discuss to you some cardiopulmonary circulation. If you don't memorize your cardiopulmonary circulation, that's very elementary. You better ask yourself, okay, that can I make it or not? You know what I mean? Like it's a pretty straight up advice because when you say like cardiopulmonary circulation, it's very basic. If you don't really memorize that one, that means to say that you have to double time and triple time. But it doesn't mean that you cannot make it. Okay? If probably you're telling yourself that I cannot make it because I'm very forgive me the word, but I don't want to say the word, but well, I need to double time and triple time because I cannot make it because this is very basic. I can't memorize it. No, it's not. Okay, everything is doable here. Okay, your NCLEX is very doable. Though for me it's not difficult. Okay, for everybody, for me it's not really difficult. It's just challenging. Those are two different things because difficulty is sort of like a subjective thing. It might be difficult for me, but for you it's not difficult. All right, or the other way around. Again, in general, this NCLEX is challenging. So what do I mean by that? You have to double time or triple time if you don't know the basics, for example. That's why my target is always knowing and understanding the basics, especially understanding the principles over facts. That's the secret in acing your NCLEX, especially your new generation NCLEX or next generation NCLEX. Let's go back to our lecture here. Right heart, and this is your left heart. Pretty straight up recommendation, right? Oh, see, somebody's laughing here. I mean, not recommendation, but a thought that you have. Oh, can I memorize this one? I think I need to. I think I need to memorize this because that's very basic, and that's a concept that you need to understand. Because if you understand that, everything will follow. All right, so you need to understand those topics. I'm also gonna discuss to you about cardiac output. Okay, so this is your right, and I'm talking too much, right? This is your right, and this is your left heart. Okay, let's divide it. So you will understand what are the etiology of your right-sided heart failure. At the same time, what are the symptoms of your heart failure? Quote and quote. Etiology and symptoms actually doesn't really matter that much in your CHF, okay? Because it doesn't change the manner of your management. Right or left, you are still going to give furosemide, for example. Does that make sense? Okay? Again, uh, etiology doesn't really matter. It's not really an absolute matter or factor in your in your management of your CHF, you're gonna give still your furosemide at any time, especially if your patient is having acute exacerbation or decompensated CHF or heart failure. Okay, so anatomy and physiology. All right, this is your vena cavas, right? Coming from your upper extremity and your lower extremity, right? I'm talking about here your cardiovascular system. Your cardiovascular system is basically what? Cardiovascular system is your circulatory system. So the affected organ system here in your CHF is your cardiovascular system, or also known as your circulatory system. From the word itself, circulatory, the function of that is to circulate your fluids. That's hemodynamics, to circulate your fluids, and of course your blood. Your blood contains lots of nutrients and oxygen as well, primarily to be distributed in the entire system. For example, in your brain, a major organ that controls everything, right? Including your heart, including your liver, including your lower extremities, your muscles, your GI, everything. Your renal, okay, as one of the most important organs to be given with cardiac output. Let's talk about cardiac output later on. Let's go back to this one, circulatory system or cardiovascular system. From the word itself, cardiovascular. So that means to say your heart as your pump, and your vascular, which means to say your blood vessels. This is where your blood and your fluids are being circulated, and it's being just pumped out by your heart. So basically your heart is a pump, okay? And your blood vessels are the containers, okay? So I'm gonna draw something like this. So it's an additional knowledge. I hope I can extend. I don't know, because this is not a an hour discussion. This is going to be a lot. So this is your tank, for example, right here. That's what I'm talking about. That's the container. This is basically your circulatory system or cardiovascular system. This is how I explain to you what is a cardiovascular system. Okay, a very important concept. And right here, this is your pump. This is your a tank, which contains water. Okay, which contains water. It's represented by your blood. Okay, circulating in your blood vessel. So your tank right here, I'm gonna draw like this. This is your tank, which is the container, which contains blood. And right here, the arrow. Just look at my arrow here, and this is your heart. So in order for you to pump that, I'm gonna draw something like a brain in here. So this is your brain. Like I said, that's the most important organ, a major organ to be perfused with the blood, which contains oxygen and as well as your carbohydrates as the primary nutrients for you to make ATP, right? So this is, again, let me label it again. This is your tank, which contains your fluids, and that is basically your blood. Okay, so I'm gonna put an arrow, your blood, and this is your heart right here, and this is your brain, the most important organ to be perfused. Okay, your heart is basically your pump. Your blood cannot go to your brain without the presence of your pump. Okay, you need to perfuse this brain because that's the most important organ in your body to control everything. All right, and you have an enough container, like the size is just adequate enough to accommodate the blood in order for you to also contribute in perfusion to the major organs like your brain. So it really has to be like consistent to one another. So your heart and as well as your tank, which is your blood vessel, and at the same time your blood. The most important is your brain, and your heart acts as a pump to effectively distribute your fluids, your blood, into the most important organs in your body, like your brain. Okay, you have to have a good size of your tank. When I'm talking about the size, I'm talking about either you vasodilate and you constrict. If you vasodilate, good distribution, all right, but not too much, just enough vasodilation. Okay, because remember, your blood vessels are semi-permeable. If you also have vasoconstriction, that's gonna be a problem. All right, it's okay to have a good vascular resistance or constriction, because that means to say that your blood can also go, like a little bit of pressure, so that your blood will be propelled or distributed to the organs, right? You need some systemic vascular resistance, your SVR as well, to distribute your blood. Okay, so the blood vessel, that tank, can change in size. It's either you vasoconstrict or you vasodilate. The pump can be, can be diseased as well. For example, in the presence of your CHF, it may not pump well because primarily your CHF is a pump failure. It may not pump well to distribute your, or to effectively distribute your blood into major organs. Okay, in the presence of your CHF, for example. Okay, so that's how you understand. These are the most important concepts that you need to understand. What is cardiovascular system, circulatory system, which will circulate your blood effectively into the entire, organ system. All right, let's start it off again. I think I got stuck up here in this drawing. So this is your superior vena cava, right? Let me put it in white again. So the blood that goes circulatory system, right? So you expect me to draw some arrows. Okay. So from New York is Sweet. Hello there in New York. Probably it's I think it's, no, the time is 1 hour advance than here in Texas, right? Or 2 hours. If I'm not mistaken, I think it's 1 hour, right? And this is another arrow from your inferior vena cava. This is SVC or superior vena cava. IVC is inferior vena cava. So the arrow from your superior vena cava, which is the blood coming from upper extremities, from the head, for example, or from the arms, goes right here on this arrow. From the lower extremities is your, inferior vena cava, and it goes into your right atrium. This is the arrow. That's your right atrium, and it goes into your right ventricle. To prevent backflow, it has to have a certain, a certain portion there, which is your valve, again to prevent backflow. That is what we call as your tricuspid valve, and it goes into your pulmonary artery. This is your pulmonary artery that goes into the lungs. If you notice, this is blue colored because it's less oxygenated. It goes into your lungs to pick up some oxygen. I'm talking about your blood. I'm talking about your, your RBCs, to pick up oxygen and to dump your, your carbon dioxide, and the lungs is able to like eliminate it through the process of your expiration, right? And then you're going to inhale, and then of course your RBCs is going to pick up some oxygen as well, and it goes back to the heart. Okay, so this is going to the lungs. Can you follow? To pick up oxygen and to dump and eliminate your carbon dioxide. It's eliminated through the process of expiration. It's going to pick up oxygen again, like I said, from the lungs and going back to your heart. This time we are discussing about the left. Okay, it goes into your left atrium. After your left atrium, it goes to your left ventricle to prevent backflow as well. To prevent backflow, you also have your bicuspid valve there. Okay, we need that, right, to prevent backflow. And that blood coming from your left ventricle goes into your aorta and into the entire system. If you notice, guys, this is colored red because it's already, or it has already picked up some oxygen from your lungs. Okay, it's already red, containing oxygen, and you need that together with your, of course, your sugar into many other systems in your body. Okay, this is process. This is process, guys. So let me clear it out. Let me clear it out. Come on. Let me clear it out so I can explain more. All right. Okay, so this is your right atrium. Let me just label it. And that is your right ventricle. Okay, CHF. How many types of CHF? Of course, you will answer me. How many types? We have left and right CHF, right? Left CHF. Let's start it off with your right muna. And your left CHF. Right CHF and your left CHF. Those are the two things now to remember. Right-sided CHF and your left-sided CHF. Okay, what do you mean by that? Remember, this is CHF, congestive heart failure. Your heart is failing, okay? Either failing from the right and failing from the left. Okay. When you say like failing from the right side, this one is failing for some reasons, right? For example, like your valve is not working. If the valve is not working, and there's like a form of backflow there, what will happen? Okay, it will actually increase the pressure. If the pressure is too much, and then it will fail. All right, what will happen to the arrow here? What will happen to the arrow? The arrow backflows, right? If it backflows to your vena cavas, again, if your right side portion of your heart is failing, Okay, what do you expect? Pressure will build up. Okay, for example, like it's because of the bulbs, the tricuspid bulb is not working. Okay, and then it backflows to your vena cavas and as well as your inferior vena cava. So what do you expect? This is talking about fluids. It will pull in your brain. It will cause too much pressure in your brain. It will cause jugular vein distension. These are the signs and symptoms. And it will also backflows to your inferior vena cava. It causes ascites. Okay, it causes splenomegaly. It causes hepatomegaly. It causes edema, peripheral edema. All right. So through your superior vena cava and as well as your inferior vena cava. So that's gonna be a problem. So the symptoms related to your right-sided heart failure is more on to your systemic, related to your systemic venous circulation, because it backflows to the brain through your superior vena cava, at the same time your inferior vena cava, causing what? Edema, for instance. That's the usual, symptom of your peripheral edema, symptom of your right-sided heart failure. Let's go to your left side. Okay, to your left side, guys. Left-sided heart failure. In other words, the left side is failing. All right, this side here is failing. What do you expect? What do you expect if the left side portion of your heart is failing? So instead of the arrow going towards this way, it will backflow because it's already failing. Too much pressure. What happens is that it will go back to the lungs. All right, it will go back to the lungs. What will happen? The fluids, this is talking about circulatory system. This is talking about the fluids in the tank. All right, and it goes back to your lungs, causing what? Pooling of fluids, causing pulmonary edema. This time it's not peripheral edema. This time it's pulmonary edema. So you expect that your left side portion, the left-sided heart failure causes what? Respiratory symptoms. All right, respiratory symptoms. And what are the usual cause of your left-sided heart failure? The usual cause of your left-sided heart failure is your MI. Okay, your myocardial infarction. Myocardial infarction is is a type of acute coronary syndrome. In other words, coronary means to say what? Coronary is the coronary artery, talking about your coronary artery supplying blood to your myocardium. Okay, and that whenever you don't take care of your coronaries, it will cause some plaque formation, and eventually it will cause some clot formation. So plaques and clots are two different things. It could be a fatty plaque, and then eventually it will lead into clot formation. And what will happen? It will cause significant blockage to your coronary artery. Okay, if you notice also, if you are going to block your coronary arteries, it will bring damage to your what? To your left side portion, because your left side portion is the most demanding portion of your heart, considering the muscles are very thick. The good thing about it is that it is supplied by coronary artery, which is also large. The LAD, particularly your left anterior descending artery, is one of the largest. That's the usually affected artery in your acute coronary syndrome that may lead into myocardial infarction. Well, like I said, left side portion is the most demanding because the muscles are thicker. So it needs like it needs to contract. It needs to contract well, right? Because of the demand of your major organs. Okay, so it's prone to what? It's prone to damage. Okay, it's prone to disease conditions. So what will happen then if you have acute coronary syndrome? That's the most common cause of your failing heart. That's the most common cause of your left-sided heart failure. Okay, so your MI. MI is the acute manifestation basically of your acute coronary syndrome. It's like a spectrum, right? It's like a spectrum. The severe form is your MI, especially of your ST elevation MI. ST elevation MI is the severe form of your myocardial infarction coming from one of the spectrums of your acute coronary syndrome. Okay? So if that is, if you have acute coronary syndrome or MI, it's not supplying blood to your left side portion of your heart, again, it will fail. Okay? So it will progressively fail. It will cause left-sided heart failure. Now, if it's failing again, the flow of your circulation goes back to your lungs. What will happen? It will pull fluids. Later on, it will cause pulmonary edema. Okay? So again, right-sided portion is more on to the systemic venous circulation. All right? And left-sided is more on the same. I'm talking about the symptoms. It's more onto your left-sided symptoms. All right. I'm talking about your respiratory. All right, respiratory symptoms. I told you, I'm not gonna discuss one by one the signs and symptoms and the etiology. Okay, it doesn't change the manner. It doesn't really change the manner of your management. Okay, of your congestive heart failure. You're still gonna give the basic medications that you're giving. Okay, so CHF, right-sided CHF in terms of symptoms, and left-sided CHF. Another classification is what? We have systolic CHF, and as well as systolic CHF and your diastolic CHF. Diastolic CHF. Systolic CHF is basically what? When you say systolic, this is something to do with pump failure. Systole is contraction, so pumping. So pump failure. Diastolic failure is more onto your filling failure. Filling failure, in a sense, diastole is what? Relaxation, because during relaxation, your heart is filling blood to your ventricles, particularly in your left ventricles. And remember, in your left ventricles, it's already oxygenated. Okay? So it has to be oxygenated. This is before you eject that to the entire circulation. So when your heart is failing with regards to filling, okay, what will happen? It's a filling failure. In other words, you are not able to fill in blood into your ventricles. So that will compromise your cardiac output. So let's talk about your cardiac output, guys. This is what we need from your heart. So basically, this is what we need from your heart, your cardiac output. Your cardiac output is, let's write it here. Your cardiac output is equal to MAP, or your mean arterial pressure. Okay? You get your mean arterial pressure from your what? 2 diastolic blood pressure plus 1 systolic blood pressure. Divide 3. In other words, this is talking about blood pressure. Okay? Your MAP, your mean arterial pressure, is equal to cardiac output. Your cardiac output also is equal to what? Your heart rate. Okay? It runs in 1 minute, of course, times your stroke volume. Okay? Your stroke volume is actually a product of your end diastolic volume, which is about 120 ml. Okay? If you don't understand this much, and then you have to repeat it. Okay? Repetition is the key here. End diastolic volume is the amount of blood every end of your diastole. In other words, every end of your relaxation. Okay? That's about 120 ml. So whenever your heart relaxes, it will fill in diastole. Remember, diastole is about filling. It will fill in blood into your heart, into the chambers of your heart, particularly your ventricles. More specifically, your left ventricle, because that's the most important part. That's about 120 ml. Again, end diastolic volume is the amount of blood filled in your ventricles whenever they will relax. Okay, it's very important. It's something about a volume, something about your volume. Okay, so end diastolic volume minus what? Minus or subtracted with your end systolic volume. So end systolic volume, from the word itself, systolic, which means to say what? Contraction. So this is the amount of blood whenever they contract or after they will contract. So this is about 50 ml. Again, this is already after contraction. It means to say it's a lot lesser than your end diastolic volume. End diastolic volume is the amount of blood filled in your ventricles when they relax. And end systolic volume is the amount of blood after they contract. So that's about 50 ml. So when you total this one, stroke volume is about 70 ml. Okay, in a normal individual. Heart rate is about 70, right? It's about 70. A normal individual should have like 60 to 100. Let's just put like 70 ml. So when you multiply your heart rate and your stroke volume, that's about 4,900. Let's just say 5 liters of blood. That's the total amount of blood in your body. Okay? In a normal human individual, that's about 4 to 5. In other words, in a single minute, all right, in a single minute, all, your blood, practically speaking, all your blood, the volumes of the total volume of your blood circulates into your heart and into your lungs to pick up oxygen and goes back to the heart and distributed as a perfusion to perfuse your brain and all the other major organs in your body. Okay, that's your cardiac output, by the way. Okay, I would like you to tell you something about this, the stroke volume. Your stroke volume is affected by what? The contractility of your heart. Okay, so these are the parameters. So we just specified it using your end diastolic volume and your end systolic volume, right? So your end diastolic volume and your end systolic volume, your stroke volume is influenced by your contractility of your heart contractility, the muscles of your heart, the myocardium. It's also influenced by what? It's also influenced by your preload. Preload is basically stretching, all right? Preload is basically stretching. Preload is basically stretching, and this is talking about the volume. Why it's talking about the volume? Okay, because the more you stretch your heart, the more ventricular filling it will go to the chambers of your heart. Okay, and we have this what we call as your Starling's law. The longer you stretch your heart, the stronger your myocardial contraction is. Okay, again, Starling's law. So this is influenced also by Starling's law. Well, this is getting deeper now. Starling's law. So what do you think about your knowledge now in your cardiology? So you have to assess. You have to assess your knowledge if you really know this, because NGN, next generation NCLEX, answering case studies is not just answering simple things. It's actually coming from your what knowledge, connecting the dots. What is Starling's law? What is preload? Something about the volume, contractility. It may seem too much, but if you know these principles, everything will follow. Okay? Everything will follow. So you might ask me, like, this is deep. No, it's not. That's why NGN, I told you, I mean, patients are getting more complex and complex. We need to keep up with the knowledge of the doctor. So we'll be able to what? Carry out what is best for our patients with complex disorders. You know what I mean? That's why you have to build up your knowledge like this. It's very important. Actually, this is very basic if you think about it. Okay? So contractility, we have the preload, stretch, the stretching of your heart. And this is talking about Starling's law. Starling's law is the longer it will relax. I'm talking about your muscles, the harder or the forceful the contraction is. So when you fill in, because it relaxes well, it fills in volume. So more volume is filled in your ventricles. So the more volume in your ventricles, the more blood the more blood contained in your ventricles, which is oxygenated. And when it contracts really forceful, it will bring about good cardiac output. Does that make sense? That's your preload. It's influenced by your what? Starling's law. Preload is basically stretch. The more you stretch it, the more volume of blood containing. That's ventricular filling basically. And also, we also have your afterload. Okay, the afterload. So afterload. This is the amount of pressure that needs to be overcome. Okay, for example, let me go back to your heart here. So this is your aorta. If your aorta is diseased because you have a systemic hypertension, so this will cause you to have arterial, hypertension. This will cause you to have a very tense aorta, causing lots of pressure. So you need to eject that blood into your aorta, but the aorta is diseased. Okay, you have long-standing hypertension, for example. So what do you think will happen? It will just simply backflow. All right, it will simply backflow to your left ventricle. So you need to overcome that. So afterload is the amount of pressure that you need to overcome. I think I'm really running out of time. I'm talking too much. I think I'm only allowed for 1 hour. Is that okay to extend more? Because I told you earlier that I'm going to discuss, more specifically about medication. I don't know. If you are learning, and just say yes, and then I'll continue. Guys, are you okay? Are you okay with these kinds of concepts? All right. So your stroke volume is influenced by contractility, your preload, which is the stretching of your heart, and as well as your afterload. Afterload is the amount of pressure that your heart needs to overcome. So that amount of pressure is coming from your aorta. So one specific problem that increases your afterload is your arterial hypertension, because it will reflect in your aorta. It will also reflect in your heart. If you notice, it's something about circulation. Everything is connected. Everything is connected. All right, so let's continue. So these are the things, your contractility, your preload, and your afterload. I'll go back to this concept later on once I discuss about your heart. When you have a heart failure, question is, actually this is not anymore a question. Is your heart stressed? Definitely, it's stressed out. Okay, definitely it's stressed out. Okay, so you don't want to stress out your heart some more. That's the principle of your medications. That's why you give medications, because you don't want to stress out your heart some more. Remember, this is a chronic disorder. This is a long-standing disorder. If it's a long-standing disorder, it means to say that progressively, every now and then, it's killing, it's giving stress to your heart. So you don't want that. You want this patient to live a little longer. So you give medications that will not stress out their heart. Okay, because if you are going to stress out your heart, this is where the complications comes in. What's the complication of your CHF? The severe form of your CHF, wherein your heart is not or cannot effectively distribute blood to the point that your blood pressure is too low. That is already your cardiogenic shock. Cardiogenic shock is a circulatory shock. Right? It's a circulatory shock, which means that your heart is not anymore effectively or cannot effectively distribute blood, to the entire system, and it's manifested by your what? Low blood pressure. All circulatory shock, like your cardiogenic shock, is basically low blood pressure. Okay, so it's something about your circulatory system again. So again, you relate that to the functions of your heart as the pump. Again, your cardiogenic shock is the severe form of your CHF. In fact, that's the really the culprit of your cardiogenic shock. Pump failure. If you see the books, you see cardiogenic shock as what? Pump failure. What we're talking here, it's pump failure. For example, like pump failure, one type of your congestive heart failure, but it doesn't stop there, because there's also one type of heart failure. Anyway, cardiogenic shock, we don't want that, because again, it will really kill your patient. And the principle of your management, the medication, is to lessen the stress in your heart. If you lessen the stress in your heart, and everything will follow. You will also lessen the burden to your brain, burden to your the symptoms, or burden to your renal system, on all the rest of the major organs in your body. Okay, so let's talk about, where am I now? Let's talk about the medications. There you go. Let's talk about the medications. Give me the let me put it in whites. Give me the classification of your metoprolol and carvedilol. Come on, guys. Give me the classification of your metoprolol or carvedilol. Remember, this is LOL. I wanted to see it from you guys, from your screen. Again, now, why am I discussing this in the first place? Because most of the time, you will get CHF case studies. So it's just about time to go back again to our concepts. All right? It's easier now, because there's lots of lectures in your program, if you have your program, that talks about how to answer case studies. But the question is, how can you dig in some information to answer your case studies? That's why we're going back to our concepts. Metoprolol and your carvedilol, these are LOLs. These are beta blockers. Okay? What about your lisinopril? What about your lisinopril, guys? Lisinopril. Lisinopril are ACE inhibitor. Okay? Lisinopril are ACE inhibitor. ACE inhibitor is what? With the prils, ACE inhibitors are angiotensin converting enzyme inhibitor. Angiotensin converting enzyme messes up everything. You need to prevent that from happening. I'm talking about this mechanism. That enzyme is produced by your lungs. I'll discuss that later on. So losartan is also something to do with angiotensin. This is angiotensin receptor blocker. Angiotensin receptor blocker. If you notice, angiotensin, right? So these are the substances that are role players, big role players in stressing out your heart. So we are preventing that from happening by giving inhibitors like this. Okay? So furosemide is what? Furosemide is a loop diuretics. All right? It's a loop diuretic. So these two here, and this one is your thiazide diuretic. Okay? So loop diuretics, both of them are diuretics. I'm just gonna abbreviate it. All right? So loop diuretics is your furosemide. You know that very well. especially given in the acute exacerbation of your CHF. I told you CHF is a chronic disorder that it's only waiting for exacerbation, or also known as your acute decompensated heart failure. When you say in medicine decompensated, it means to say that your heart is fully maxed out. It's losing physiologic balance. It's okay to compensate, right? It's okay to compensate, but the compensating is not good, because compensating is still you have, your physiologic balance to keep your balance, but decompensating is not good because you are already losing your physiologic balance. In other words, if you translate it to your heart failure, your heart is already maxed out in the presence of your acute exacerbation, and as well as your acute decompensated heart failure or acute decompensated heart failure. That's why you give furosemide as a diuretics, because you wanted to eliminate excessive fluids. You wanted to relieve the shortness of breathing of your patient coming from what? Pulmonary edema. Okay? So other than that, we also have some diuretics here. This is also a diuretic, right? But more particularly, this is an aldosterone blocker, right? This is an aldosterone blocker. Digoxin is a cardiac glycoside. This is a cardiac glycoside. I'm just gonna write it through this way. It's a cardiac glycoside, but we don't want to give digoxin, because digoxin is what? Digoxin is a very toxic kind of. It's a last resort. It's a very toxic kind of medication which will kill your kidneys later on. And if you are going, quote unquote, take it down to your notes, guys. And if you're going to give the digoxin as well together with your furosemide, combine it together, it will bring about more toxicity to your digoxin. Okay, more toxicity to your digoxin. It will actually, three folds or two folds will bring toxicity to your kidneys primarily. So it's a cardiac glycosides. Okay. So the butamine and dopamine, these are to increase your blood pressure, especially given for a patient having cardiogenic shock already. Again, cardiogenic shock is, of course, low blood pressure, wherein you want this patient to have increased blood pressure. So give the butamine or dopamine, especially in the last stages of your heart failure. Cardiogenic shock is usually in the last stages of your heart failure, especially if you don't take care of it using these medications and many other, interventions. Okay, hydralazine is an antihypertensive. I'm just gonna put here, the butamine and dopamine as to increase your blood pressure. I'm gonna include here, because they always gonna ask you about this, your milrinone. Okay, these are actually different, different medications. All right, but all for the purpose of what? Different medications in terms of its mode of action, but its specific mode of action, but definitely it will bring about increase in your blood pressure in the presence of your cardiogenic shock. Hydralazine, isosorbide, and hydralazine, isosorbide, these are to decrease your blood pressure. These are anti-hypertensive medication. So it will bring about low blood pressure because, hypertension is, we don't want hypertension. We don't want our afterload. Okay? So it will somehow decrease it will definitely or primarily decrease your afterload. Okay? So you won't stress your heart. So decrease afterload, and then you will not stress your heart. Let's start it off with your, okay, are you ready with my with my some physiology here? Let's go back to our physiology. Why are you giving your beta blockers first? Why are you giving your beta blockers first? Now, in your heart failure, decrease cardiac output or increase cardiac output? Come on. Is it increase cardiac output or decrease cardiac output? Come on, guys. I want to see it from your chat room. In your heart failure, remember, what you want from your heart is a cardiac output in a normal individual. But if you have heart failure, what do you expect? Decrease cardiac output. Am I right? Come on. I want to see your answers. Come on. I want to see your answers. I want to see your answers. Decrease cardiac output. All right. So decrease cardiac output. Now, if you have decreased cardiac output in your kidneys, let's start off with your kidneys. If you have decreased cardiac output in your kidneys, let me draw a little bit about kidney. Ayan, si kidney. There you go. That's your kidneys, guys. And then it's your bladder, and then you urinate, right? So these are your kidneys. If there is decreased cardiac output in your kidneys, It's a normal response for your kidneys to produce what? Renin. All right? Renin coming from your what? Your juxtaglomerular apparatus. Apparatus is composed of three different cells: your granular cells, lacy cells, and as well as your macula densa. I'm not gonna dwell about that. Your juxtaglomerular apparatus. This is actually, an apparatus, cells in your kidneys that is very sensitive to low perfusion or low cardiac output. All right. So in other words, this is stimulated. So renin is produced. This is a substance that will circulate. It will go to your liver. Here comes the liver. There you go. That's the liver. It will go to your liver and will tell your liver, hey liver, can you make a substance? All right. Can you make a substance that will bring about increase in your cardiac output or increase in your blood pressure? So basically, if you have decreased cardiac output as well, you also have decreased blood pressure, right? So, collectively, decreased cardiac output. Renin will tell your liver, can you make certain substance, all right, to bring about increase in your cardiac output or increase, blood pressure specifically, all right? So this is your angiotensinogen, okay? So the liver this time will produce angiotensinogen, okay? Angio means what? Blood vessel. Ogen is a complex form, so it needs to break down into a form of angiotensin 1. Okay, that's your angiotensin 1. There you go, angiotensin 1. Angiotensin 1. All right. Oh, am I talking about beta blocker here? This time around, this time I'm not gonna talk about beta blocker. Later on, I'm gonna talk about beta blocker. I'm talking about the ACE. So this is basically your RAS system. Okay, this is your RAS system. Your renin, angiotensin, your renin, angiotensin, and aldosterone system. So we're done with your renin, which is being produced by your kidneys. It will circulate in your blood. It goes into the liver to break down your angiotensinogen. Angiotensinogen is a complex form. It needs to be broken down into angiotensin 1 in the presence of your what? In the presence of your, what enzyme is that? In the presence of your ACE, angiotensin converting enzyme. In other words, it will convert your angiotensin. I mean, no, not yet. So angiotensin is broken down first to your angiotensin 1. Angiotensin 1 is to increase your blood pressure. However, this is not potent. All right? It will increase your blood pressure. However, it is not potent. So it needs to be broken down. There you go. It needs to be broken down into angiotensin 2. Angiotensin 2 is a potent. This is a menace. This is a bad boy here. Okay? It will increase your blood pressure too much. In other words, it's a very potent vasoconstrictor. This is a very potent substance that will bring about, increase in your blood pressure. This is converted. Your angiotensin 1 is converted from angiotensin 1 into angiotensin 2 in order to become a very potent substance or a hormone. So through your ACE. Your ACE is produced in your lungs. I'm gonna draw something like a lung here. I mean, lungs. All right. So let me review first. Renin is produced by your kidneys. It will circulate. It will go to your liver. Hey liver, can you break down your angiotensinogen? So the liver will break down your angiotensinogen into a simple form, which is angiotensin 1. Angiotensin 1 increases your blood pressure, increase cardiac output. However, it's not really potent. You need to have a certain chemical or substance that really brings out increase in your blood pressure. But we need to have a substance or an enzyme, and that is your ACE. Okay, your ACE. So angiotensin converting enzyme from 1 to 2. 2 now is a very potent substance that will increase your blood pressure. Okay? There are three things that will happen here. Your angiotensin 2 will stimulate your what? Is what going to happen here in relation to what I'm discussing. Okay, earlier. So this is your blood vessel. There you go. This is your blood vessel right here. It will stimulate your blood vessel. Okay? Remember, these are substances. This is going to what? Bind to a specific receptor. Okay, specific receptor. This is what we call as your angiotensin 2 receptors. Okay, in order to produce an effect. So what's the effect on this one? Vasoconstriction, increase in your vascular resistance, increase in your vascular resistance. That means to say that it causes, constriction. It causes constriction. So what will happen if your blood vessels are constricted? Let's go back to your heart here. Let's go back to your afterload there. So if it constricts, does that increase your afterload? Yes, it will definitely increase your afterload. So does that stress out your heart? Yes, it will stress out your heart. Okay, it will stress out your heart. Again, angiotensin 2, when it binds to specific receptors in your blood vessels, it will cause what? It will cause vasoconstriction, increase in your vascular resistance. This is basically the purpose of your angiotensin mechanism, to increase your blood pressure. Vasoconstriction. Does that increase your afterload? Yes. Does that stress your heart? Yes. Is that what you want to happen to a CHF patient? You don't want that stress. That's why you need to give a medication to block this. Okay? Other than that, your angiotensin 2 will cause what? It will stimulate it will also stimulate your adrenal glands. Okay? To what? To increase the levels of your what? Increase the levels of your aldosterone. Aldosterone. Okay? Increase the levels of your aldosterone. So increase the levels of aldosterone. What's the effect of your aldosterone? Increase retention of your sodium, at the same time your water. Increase sodium retention and water as well. So what do you mean by that? What's the implication? Increase in your blood pressure. Okay? Increase in the blood pressure, does that stress out your heart, your afterload? The same thing. Yeah. Does that stress out your heart when you retain your sodium? Of course, that's increased volume. Does that affect your preload? Yes, it will affect your preload. Does that stress out your heart? Yes, it will stress out your heart. Okay? So that's the adrenal. See? We have angiotensin, renin, we have angiotensin, and lastly, your aldosterone. Does that also affect your brain? Yeah, it also affects your brain. By what? By stimulating to increase the levels of your antidiuretic hormone. When you release your antidiuretic hormone as well, it will also retain fluids in your kidneys. So that's another, effect of your angiotensin. Okay? So, in relation to your medications, guys, in relation to your medication, you give what? You give your angiotensin blocker right here. Okay? We have angiotensin blocker, your angiotensin enzyme inhibitor, sorry. So we have your ACE inhibitor, and as well as your what? You block this ACE from converting your angiotensin 1 to angiotensin 2. At the same time, you're also blocking your what? Your angiotensin 2 using your ARB. So does that help? Yes. You block this mechanism in order for you to de-stress your heart. You don't want to stress your heart some more because, again, you have a heart failure. Okay? So let me talk about your beta blockers this time. Does that make sense? Okay. So I told you this mechanism here, the RAS mechanism, is really has a role in stressing out your heart some more. That's why you give your angiotensin converting enzyme inhibitor, and as well as your angiotensin receptor blocker. Okay, because you wanted to block this mechanism in order for you to de-stress your heart. Let's talk about your beta blockers. Okay, this is your kidneys, right? So this time I'm gonna draw something like a brain. Okay, this is your brain right here. Okay, that's your brain. Sorry for my drawing, guys. So your brain innervates your heart. This is your heart right here. When you say innervates your heart, it will stimulate your heart to do something, right? Okay, this is your heart. And so this is your brain innervating your heart, and it causes increase in your heart rate. I'm talking about the sympathetic nervous system. And it also, innervates your heart muscles to increase your contractility. This is what the sympathetic nervous system is doing. Okay? So, here, in decreased cardiac output, guys, in decreased cardiac output, because of CHF, it will also stimulate your heart. Hey, I'm so tired. Can you do something for me to really max out what I usually do? So it will stimulate your heart, your brain, to innervate your heart some more, again, to effectively function normally. All right, but the thing is, you cannot correct the problem, right? Because you already have an existing CHF. It's like a vicious cycle. It's like a vicious cycle, really. Okay, so increased heart rate. This is your heart. I'm gonna make it in red. Increased heart rate, increased contractility. Increased heart rate is basically what? Chronotropic effect. Okay? Increased contractility is basically inotropic effect. Okay. So how do they what's the mechanism here? They will release, certain substances, neurotransmitters, which we call as your norepinephrine, to bind into your beta 1 receptors. Okay? To bind into your beta 1 receptors. Okay, so if it binds to your beta receptors, it increases the heart rate, okay, chronotropic effect, and it will also increase your contractility. Again, in your CHF, it decreases your cardiac output, okay? It decreases your cardiac output to the point that it will stimulate your brain to do something about it, and it will innervate, it will stimulate your heart to increase heart rate and to increase contractility, right? By or through your what? Through your norepinephrine binding to your beta 1 receptors, that's chronotropic effect. At the same time, in your muscles, contractility, that's your inotropic effect. Norepinephrine will bind to your beta 1 receptors to cause inotropic effect, right? Because again, you want your heart to function normally. Okay, so what's the role of your beta blockers here? I'm gonna make it in yellow. Okay, what's the role of your beta blockers here? Your beta blockers, like your olol, all right, your metoprolol, will block this thing. Okay, I'm gonna block you. So your metoprolol decreases your heart rate, it relaxes your heart, it de-stresses your heart. That's why it's given in your CHF. Did you get the principle here? And it decreases the contractility as well. All right, it decreases your contractility. In other words, it decreases your inotropic effect. Okay, it decreases your inotropic effect. Again, beta blockers, it will block the binding of your norepinephrine and your beta 1 receptors to decrease your heart rate and to decrease your inotropic effect, your contractility. So it basically relaxes your heart. Okay, it basically relaxes your heart. And one thing is your metoprolol. Your metoprolol. That's why you see your patient. That's why you see your patient being given with metoprolol. Okay, your patient is being given with metoprolol, your beta blocker. Okay, let's talk about your carvedilol as well. Carvedilol. What's the difference versus your metoprolol? The good thing about your carvedilol is that it will also increase your heart rate. I mean, it decrease your heart rate by causing negative chronotropic effect, just like your metoprolol, and decreases contractility as well. The good thing about your metoprolol as well is that if your brain is going back to this mechanism, it will also what? It will also stimulate your blood vessels, all right, to increase its vascular resistance, systemic vascular resistance, okay, in the presence of your low cardiac output into your blood vessels, not only in your heart, by binding to your alpha receptors, alpha 1 receptors. Okay, alpha 1 receptors this time. Again, this is norepinephrine and it binds to your alpha 1 receptors to increase your vascular resistance. The good thing about your carvedilol is that it doesn't only block your beta 1, it also blocks your alpha 1. So it's like an alpha 1 receptor blocker at the same time, primarily your beta 1 blocker. Okay? And it's not only that, it actually also blocks your beta 2 in your lungs. Your carvedilol, that's why it can trigger asthma as well. In the context of NCLEX, they might ask you about that because carvedilol, metoprolol is good in a sense, beta 1, because it's just selective to your beta 1, but carvedilol will block your beta 1, will block your alpha 1, and will also block your your beta 2. That's why it can trigger asthma as well. In other words, it's non-selective. It's a non-selective kind of beta blocker because we have two, right? Your cardioselective and your non-cardioselective. Cardioselective is, only to your heart, and non-cardioselective is not only your heart, but at the same time your lungs. Okay? So that's the difference between your carvedilol and your metoprolol. All right. So again, all for the purpose of de-stressing your heart because it's already stressed out in the presence of of your heart failure. Okay. I guess I'm gonna discuss some more because this is a lot to discuss give you more information or a more detailed explanation. I'm just gonna finish it with your furosemide because this is the usual thing that we are giving, right? Especially in your acute exacerbation. Okay, so so CHF, right? CHF. I'm gonna begin it here again in your CHF. I told you earlier, if you have CHF, it's a chronic disorder. It's just waiting for acute exacerbation or acute decompensated heart failure. Okay, acute decompensated heart failure. So in other words, from chronic to become acute to becoming acute, we don't want acute exacerbation. Acute exacerbation is manifested by what? Shortness of breathing. All right, manifested by shortness of breathing. They are always gonna ask you about complications because this is where you exercise your clinical reasoning, your critical thinking, your clinical judgment overall. Okay, so NCLEX is always going to ask you about medications like furosemide because again, furosemide is the gold standard of CHF, especially if they have acute exacerbation. Okay, so let's hear it from your furosemide. Well, it's very easy. Furosemide is a kind of medication that will eliminate, of course, you know this very well, that will eliminate excessive fluids that causes you to have pulmonary edema. So you're eliminating excess fluid so that your patient will be eased from shortness of breathing, from acute exacerbation. Okay. In acute exacerbation, let me write it here, guys. In acute exacerbation of your CHF or acute decompensated heart failure, so what you will do is this mnemonics. So this will help you. Okay, this is what you do if you have acute exacerbation of your CHF. What's letter L? What's letter L? This is basically your Lasix. Lasix is the brand name of your furosemide. What is letter M? Morphine. Okay? What is morphine? It's a narcotics, right? It's a narcotics that will bring about relaxation of your patient because you don't want to you don't want to stress out your heart some more. That's your morphine. All right? So it will bring about some form of a relaxation kind of medication as a narcotic and will bring about comfort to your patient. Letter N is what? Nitrates. Okay. Nitrates is basically your what? Nitrates is basically this one here. If you notice, I put some isosorbide nitrates or dinitrates. That's your letter N, which is your nitrates. Nitrates is a vasodilator. If you vasodilate your blood vessel, that will bring about less afterload. If it's less afterload, that means to say what? Your heart is not it's not stressed that much. So that's your nitrates. It's a vasodilator, specifically a venodilator, right? It can also cause like arterial dilation, but primarily it can cause venodilation. Okay, it works more onto the venous end of your blood vessel. Letter O stands for oxygen. Remember, this is a respiratory problem. If you have an acute exacerbation, in other words, it's really a priority. So you give oxygen. And lastly, positioning. You position your patient on an upright position. Okay? You position your patient on an upright position to ease their breathing difficulty during acute exacerbation because again, this is a priority in your the management of your acute exacerbation of your CHF, upright position. Okay. If your patient, for example, after how many days responding to medications, admitted in the hospital, responding to medications, and if they are able to lie down flat, that's a good sign. It means to say you don't need to, instruct them to upright position, all right, to ease their breathing. In other words, they are ready to go because they're just lying flat. So that's one sign. Even if you don't really dig into to interview your patient, as long as you see them lying flat, coming from an acute exacerbation, I guess this patient can go home. That's the deciding factor there. Of course, it has to be evaluated using your X-rays, using your chest X-rays to see that there is no pooling of fluids or pulmonary edema in their lungs. All right. So that's one way to validate it. Again, this is your mnemonics in your acute exacerbation of your CHF. Okay. So questions so far? Questions so far? So let me see. What I need to discuss here. Furosemide is already there. I've already discussed about furosemide. Your metolazone and as well as your hydrochlorothiazide, these are diuretics. These are diuretics that are opposite to your furosemide, but both of them eliminates excessive fluids. What's a good thing about your furosemide is that furosemide is or can act really quick. So it will bring about ease in your difficulty of breathing related to your pulmonary edema, left-sided heart failure. Hydrochlorothiazide and your metolazone are thiazide diuretics, okay, which acts a little slow than your furosemide. It's a very effective medication as well. The difference between the two of them is that furosemide will waste your potassium, so be careful using your furosemide because it will cause, a hypokalemia because it's a potassium wasting diuretics. And as you know, hydrochlorothiazide and your metolazone also has, they are also potassium wasting diuretics. The difference between furosemide, hydrochlorothiazide, and metolazone between your spironolactone and eplerenone is that spironolactone and your eplerenone are potassium sparing diuretics. So be careful in giving to a patient having hyperkalemia. Again, furosemide, hydrochlorothiazide, metolazone are potassium wasting diuretics. Okay, so be careful about this because it will bring about hypokalemia. And spironolactone is a potassium sparing diuretics just like your eplerenone. So be careful if you have hyperkalemia. Remember, hyperkalemia, as long as it's potassium imbalance, it will cause you to have cardiac arrhythmias. Okay? Digoxin, what did I tell you? Tell you about digoxin? Digoxin is not usually given as a primary defense to your, to your heart failure. It's usually given as a last resort because it's very toxic to your kidneys. Check for your heart rate, of course, because it has a negative chronotropic effect. Let's just go by the specifics here, especially in your nursing intervention. Negative chronotropic effect, in other words, it decreases your heart rate. Okay. The good thing about the digoxin is that it increases your inotropic effect, even if it decreases your chronotropic effect. So negative chronotropic effect and positive inotropic effect. In other words, it increases the contractility of your heart. Okay. So digoxin, again, you also check for your heart rate because it will bring down your heart rate. Do not give it if it's less than 60. And you also check for hypokalemia because hypokalemia can also trigger toxicity of your digoxin. Okay. So again, hypokalemia can trigger toxicity of your digoxin. Okay. And digoxin is also not, you also check for your renal, panel, your BUN and creatinine. So check also for your BUN and creatinine. Okay, check for BUN and creatinine as well. Apart from checking your heart rate, check also your potassium level because hypokalemia is or can exacerbate your digoxin toxicity. Check for BUN and creatinine because it's very toxic to your kidneys. So that's why it's a last resort. And as well as check for your heart rate because it has a negative chronotropic effect. Though it has a negative chronotropic effect, but it has a positive inotropic effect that will forcefully, increase the contraction of your heart. And I told you earlier, digoxin is not usually given with furosemide. So you also check for the intake of furosemide because it can increase the toxicity of your digoxin as well into two-folds or three-folds according to many studies. Okay? Your dobutamine and your dopamine and milrinone is given in the last stages of your CHF. I haven't talked about that earlier, but well, dobutamine, dopamine, and milrinone is given to increase your blood pressure in the presence of your cardiogenic shock. In other words, your BP is, your heart is not really producing, its normal function. It's really super maxed out. It's dying already. So, well, you increase your blood pressure in your cardiogenic shock by giving dobutamine, dopamine, or milrinone. These are the drug of choices that we are giving. Okay, so hydralazine and what else? What else are the other medications I need to discuss here? Hydralazine and your isosorbide dinitrate. Hydralazine is a blood pressure lowering medication. Okay, so it causes vasodilation, especially on the arterial end, because you don't want to stress out your heart again by increasing your afterload. The same thing as your isosorbide dinitrate. These are blood pressure medications that decreases your afterload, thereby de-stressing your heart. If you notice, I'm always talking about de-stressing your heart in the presence of heart failure. These all medications are medications given to de-stress your heart. Okay? And I dwell more onto your RAS mechanism, your renin, angiotensin-aldosterone mechanism, because that's a major role player in stressing your heart. So we wanted to block your angiotensin converting enzyme, at the same time your angiotensin 2 from from dominantly causing an effect. All right. So what's that? It's like a fire alarm or something. Anyway, so this is your topic for today. So I guess I can expound it some more by discussing this mechanism. This is quite important because this is where you build your knowledge. I told you earlier, it's a pretty straight up kind of advice that if you see yourself that you don't know what a beta blocker is, okay, kindly think. Okay, I mean, yeah, please kindly think that, okay, I need to double time. Okay, I need to double time because I need to understand what is a beta blocker. This is very much pharmacology. Okay, why do I need to give beta blockers? Because I don't want to stress my heart in the presence of heart failure. Okay, why do I give lisinopril? Lisinopril is an example of your ACE inhibitor dosed with prils, because I don't want this RAS mechanism to jack up my CHF. It's messing around. So I wanted to block this ACE kind of enzyme in order for me to block, the this mechanism. The same thing as with your ARBs, your angiotensin receptor blocker. Well, what's the difference between the two? Well, if your patient cannot tolerate your ACE inhibitors, and then kindly give your angiotensin receptor blocker. And sometimes they're gonna ask you in your NCLEX that, what's the precaution when you give your ACE inhibitors and your ARBs? Both of the medications can cause hyperkalemia. So don't give it to a patient with hyperkalemia, because it will increase more of your potassium. Okay, again, your ACE inhibitors and your ARBs will increase your potassium. In other words, be cautious. Check your potassium before giving your ACE inhibitors. It's a very powerful medication, including your ARBs, because both of them will increase your potassium. So again, hypokalemia or hyperkalemia, imbalances can cause cardiac arrhythmias. Automatic. If you see that, your patient must be hooked or attached to a cardiac monitor. Whatever medications that you are giving, for example, like the digoxin, in association with your potassium, you always have to hook your patient on a cardiac monitor, hyperkalemia. Okay. So anything else? So I guess I'll see you next month for another topic. So I can probably like bring you some more case studies. I mean, some more of this discussions, like pharmacology, I guess. And yeah, so I know you are already good in answering case studies. Okay, that's why I brought you this topic, because this is what we need in answering any questions, case studies or not. This is what we need in answering questions, especially case studies, because case studies are all about connecting the dots, and those dots are knowledge. Why are you giving this for a patient having CHF, and what's the mechanism? Why you are giving this medication, and of course, what are the nursing responsibilities? Those are part of the dots. All right. So I know you feel tired while you're preparing. Give me last 1 minute. I know you're tired while you are preparing in your NCLEX, because it's gonna be a challenging one. It's gonna be a challenging one, but with hard work, I know you can make it. Sometimes you cry, but your cry is actually not only for yourself, because if it's only for yourself, that's too selfish. That's a sign of weakness. But if you cry for your family, that's a sign of strength. Okay. And if you feel like you're really tired, guys, so that means to say that you're doing something. That means to say that you are doing something. Okay. And you are doing it for your family as well. Don't stop until you get proud to yourself. Don't stop until you get this NCLEX. Sacrifice is just a temporary thing. All right. When you have your license, it's a permanent thing. No one's gonna take that away from you. God bless everyone. Trust the wait. Embrace the uncertainty. Enjoy the beauty of becoming a USRN. See you next month. Okay. Thank you, guys.